Okay, skin. Overperfused, and that's due to the fact that we have a lot of thermal regulation going on here. We have fewer capillaries in the skin. This is skeletal muscle on top. I'm going to cover that in a minute. Okay. Skin has fewer capillaries because there isn't a high metabolic need. Okay. The blood flow is increased via other mechanisms. You don't need a high surface area for exchange. We'll talk about that in a minute. It's really more involved in temperature regulation. So when it gets cold outside, here's what happens in your skin. You vasoconstrict, okay? And you get vasoconstriction, and the resistance to flow in your skin increases. And because the resistance increases, flow goes down, okay? It's that simple. All right? And because flow goes down to your skin, you limit flow to the skin, you limit exposure to the cold air, and you limit heat loss. In addition to that, we have what's called countercurrent exchange going on, and this is going to be emphasized during the course of this lecture. Okay? Countercurrent exchange is when something is transported from one area to another in order to conserve it or get rid of it, depending upon how it looks. Here's what I mean in terms of heat. Your arterial blood is warm, and your venous blood is cold, and the arteries and the veins are set up right next to each other. And what happens is heat is transferred from the warm arterial blood to the cold venous blood. And instead of being exposed to the cold air, it's brought back into your body, and heat is conserved through countercurrent exchange. Okay? This is what we mean by that. Arterial blood going out, warm, venous blood going in, cold. The heat is transferred from one to the other, and your venous blood is warmed, and you conserve heat. Okay? Those are our two mechanisms that are involved here. Now, when we look at what happens with the body when the body temperature is elevated, it's exactly the opposite. We get vasodilation, and we increase flow to the skin. Okay? And because we've reduced resistance, decreased resistance, increased flow. Okay? And heat is now transferred from the warm venous blood, which is returning from the skin, which has been exposed to all this hot air. Presumably it's warm outside. And it's transferred to the arterial side where it will be re-exposed to the outside. And it's not transferred, it limits the amount of heat that makes its way into the interior of your body, and it limits the degree to which it can increase your body temperature. Okay? Countercurrent exchange in the opposite direction. So, you will also note the existence of these arterial venous shunts, AV shunts. Okay? These are relatively large vessels that connect the arteries to the veins in your skin. And when they dilate, they decrease the resistance a lot. And when they constrict, they increase the resistance a lot. We have very few capillaries because we don't need a lot of surface area for exchange. We don't have much metabolic need there. But we do need to regulate flow, and we need big increases or big decreases depending upon what the temperature is. These AV shunts regulate that. Okay? And they're nothing more than a way to really increase or really decrease the resistance in your skin to cause big changes in flow. Okay? And there it is. Shunts are open, decreased resistance, big increase in flow. Okay? Now, you will note that your histology textbook is wrong. Your histology textbook was written by an anatomist. Anatomists look at the structures and they go, ooh, there's a connection there between the artery and the vein. It must be trying to get rid of the blood before it can be exposed to the skin. Not true. Okay? The shunts are in the skin, and they reduce the resistance in the skin, and they increase the flow in the skin. So the histology author, not being as smart as your histology teachers are, thought, well, the shunt must be there so that when it gets cold outside, you can transfer warm blood from the artery to the vein, and it'll be returned to the body. Not true. Okay? What it's doing is it's reducing the resistance. You get constriction of that shunt to increase the resistance to flow and reduce the total flow to the skin when it's cold. It does not dilate, it constricts, along with everything else, okay? So it is Ohm's law. 90% of life is showing up, 90% of the rest, Ohm's law, okay? It is not a shunt to transfer blood to preserve heat. It's there to regulate resistance. Believe me, that's the way it works, okay? So I think that's all I needed to say there, okay? GI tract must support motility and absorption. I'm sure you guys know that. Blood flow increases when you're digesting food, okay, and when the motility increases. There are a lot of neural controls. They do participate in maintenance of blood pressure when you are exercising and you need to maintain MAP. You will constrict to your GI tract because you don't really want to worry about digesting food when you're running away from a bear. Okay? So the parasympathetic effects, people think, well, there must be parasympathetic innervation. It's not true. When you increase the parasympathetic tone to the GI tract, you increase motility. That causes metabolites to build. That causes vasodilation. So it's an indirect effect. There isn't direct parasympathetic innervation to the vasculature. Okay? And a lot of blood, remember we said that blood sits in the veins, like 2/3 of it ordinarily. A lot of that sits in the veins of the GI tract. And when you vasoconstrict in the GI tract, and when you venoconstrict, when you stiffen the walls and increase the compliance, you decrease the volume of those veins, and that blood ends up circulating, and it helps maintain arterial pressure. If the volume's not in the veins, it's everywhere else. And if you increase the volume in the arteries, you'll increase the pressure. Okay, so that's another way that they participate in regulation of blood pressure, of mean arterial pressure. Note that there is a countercurrent mechanism in effect here. The GI tract by design has a humongous surface area for absorption of metabolites. That surface area is also great for losing oxygen because oxygen will fly right across it and into your bowels, which are fine with receiving it, okay? So you need to limit the amount of oxygen exposure to this huge surface area for absorption. And the way that you do that is, once again, through countercurrent exchange. Oxygen, the veins and the arteries are right next to each other, and oxygen is actually moves from the arterial to the vein, and it's actually preserved because it's returned to your body instead of being exposed to this surface area. Go ahead.
So is that also true of AV shunts?
AV shunts are not here in any great abundance. Okay, what's that? You get arterial perfusion into the capillaries here, and then the blood is returned through the veins. And there isn't really much in the way of AV shunts here. This is the way just the normal circulation works. But because these are right next to each other, the oxygen is actually removed from the artery and enters the venous blood and is returned to the body before it can be exposed to the surface area. Okay? It isn't so much AV shunts in this particular case that are really needed to massively increase or decrease flow. Okay? That's done in response for temperature regulation, okay? Okay. So I think that's all I wanted to say there. Let's talk a little bit about the liver. Notice that the liver is involved with a portal circulation now. The blood that drains from the splanchnic beds, the intestines, drains into a portal vein and then goes directly into the liver, okay? And there is an oxygen supply to the liver. It comes in primarily through the hepatic artery. So there's a dual perfusion mechanism there, okay, where the blood kind of mixes together and then perfuses the artery, okay? But you will note that because this is a vein, the pressure is low in it. you're draining blood from the intestines and you've got low pressure in that pulmonary vein. Okay. And what that means is that the perfusion pressure in the liver is relatively low, and the capillary pressure is normally relatively low. The capillaries have a special name in the liver, as you will learn. In GI, they're the sinusoids. And the pressure is relatively low, 8 to 9 millimeters of mercury. And then the pressure in the veins draining the hepatic, the liver is really low, okay? So this would lead you to conclude that there's decreased filtration in the liver because there's less mid-capillary pressure, less pressure pushing it out. And you would be correct. And it would lead you to the conclusion that there is a net reabsorption and that it's really huge because the oncotic pressure will draw water in and you'll have a huge imbalance of reabsorption compared to filtration. And in that, you would actually be wrong. And the reason is because unlike the capillaries almost everywhere else in the body, these capillaries are very permeant to protein. So there isn't much of an osmotic difference between the capillaries and the tissues. And so you've got very little filtration going on, but you've also got very little reabsorption going on. And what you have is a swamp where things just aren't moving a whole lot either way, okay? This means that it is very easy to back up blood flow in this area. So we've talked a lot about how increasing venous pressure will increase mid-capillary pressure. Well, if your mid-capillary pressure is only 8 or 9, when I increase that, that is relatively a massive increase in pressure. So when you have left heart failure and your venous pressure goes up, your capillary pressure goes up everywhere, but relative to the normal in the liver, it goes up a lot, and filtration relatively goes up a lot, and fluid accumulates in the tissue a lot, and what you get is what's called ascites, or fluid accumulation in the abdomen. And that's because this pressure difference is pretty big. All the way through here, you get what's called portal hypertension, and your splanchnic beds actually back up as well. And your capillary pressure increases there as well. And you end up, just filtering water out into the abdomen, okay? So if we look at our congestive heart failure case, she's gained weight. She's accumulated fluid in her tissues, and especially in her abdomen. And we know that because it's mildly distended, okay? And that's because of the fluid there, all right? So she has congestive heart failure, and she tends to accumulate fluid in her lower legs because of the hydrostatic pressure, in her abdomen because there tends to be fairly low capillary pressure there, and when you increase it, you increase filtration a lot relative to normal. Go ahead.
Why does the fluid leave her liver and go into the abdomen instead of like?
I think it just, I don't have a great answer to that, except that I think that, you can only get so much water into those tissues, and if it has anywhere to go, it's just going to go out. There's no skin covering it. Like there isn't this hydrophobic layer that's keeping all the water in. And that's the best answer I have. Okay? Same with the intestines. Okay? All right. Renal circulation, overperfused. We're producing urine there. Now, I am going to, it does have a high metabolic demand, but it's still overperfused. Now, I'm going to leave the details of how the kidney works to Dr. Phil. I've described it to you guys in very basic terms. You filter plasma. The plasma goes through the tubules of the kidney. You remove all the substances you want to keep, and you excrete all the substances that you want to get rid of, okay? And there's a fairly high oxygen demand. And the other thing that happens in the kidneys is that you concentrate the urine. That is, there's a net reabsorption of water so that everything gets concentrated, all right? So what happens in the kidney is that the arteries dip down into the medulla of the kidney, and the deeper they dip down, the more the osmolarity increases, and the more water is drawn out of those tubules, okay? And this is the way that you concentrate your urine, okay? The water is drawn out. So that presents a little bit of a problem. A lot of this increase in osmolarity is due to sodium that's present. And sodium goes right across these walls and accumulates in the blood. Okay? And so you get high sodium in the blood down here near the bottom of this vein. And if you were to drain this, like this, out the vein, you would lose massive amounts of sodium because the concentration would be like 1,200 millimolar here. That's over a molar, okay? So that's humongous. And you'd be losing sodium all over the place, okay? And in order to keep up, you'd have to be a sodium-eating machine. You get sick. So what your kidney has done is it's been designed so that that doesn't happen. And the vasculature dips down into the medulla and then comes back up. And as it comes back up, sodium leaves, and what you get is an exchange of sodium here. It's countercurrent exchange, and it's meant to preserve the sodium. You've used the sodium gradient to concentrate the urine on the way down in the tubules, and now on the way up, the sodium leaves the blood, and instead of draining out of the vein with 1,200 millimolar sodium, you end up with the normal amount when you finally exit into the cortex again, okay? So this is countercurrent exchange of sodium, and it's meant to preserve the sodium, okay? There is also a portal system here. The glomerulus is where the filtration takes place, and then the blood leaves the glomerulus and it enters another capillary bed that surrounds the tubules. It's called the vasa recta. And again, I'll leave the details of the mechanism to Dr. Phil. But this is a portal system where you have a capillary bed here in the glomerulus, one down here in the vasa recta, and they're connected, okay? So portal systems connect two capillary beds in series. Okay, I went through this, countercurrent exchange.